I'm really glad to be here. It's been a wonderful day of collaboration between our EPLink groups and with CanBind. And just a special thanks to Wendy about her talk, because I also live with depression and anxiety, so I can so understand some of the things that she was talking about, and just sort of being with depression, sort of sitting in a place where it's been so difficult to sort of reach out, and the importance of decreasing stigma and actually talking about that. So I just wanted to quickly talk about what the MDO does. We offer peer support services and recovery programs. I left a bunch of resources up front, but free services, drop-in peer supports for people that just want to drop in and talk about whatever is going on with them. They can just sit in the room anonymously and then just have people hear what's kind of going on. We also have some set programs similar to the programs that you guys were talking about, looking sort of at 8 weeks, sort of more standardized recovery program over 8 weeks, and those are free as well. You can get more information. Give me a chat at the end of the program. We can tell you more about that. Oh, also family programs as well. Family is really important because families often struggle with trying to support a loved one, and we have resources on how best to support yourself and also the families around you. That's super important.
Maybe, Wendy, would you say a little bit about Epilepsy Toronto? I know you volunteer with them.
I remember when I was first introduced to this group, I did not want anything to do with them. I didn't want to be known that I associated with this type of group. And then I went in, and I can call myself very difficult, and I know my friends in the audience are saying that. And they were so patient, and they give me tools to work with. We have support group, which there's a couple of members in the front. We have an adult support group, we have recreational group. We, whatever we say as a group stays as a group. We also have activities like family retreat. In the winter time, we have summer camp. There's so much things to do with this group, and that helped me to reach the acceptance of having epilepsy.
So it can be from a combination of both. Some of the epilepsy medications actually have mood stabilizing and mood enhancing effects. And in fact, there are a number of epilepsy medications which we use in psychiatry, even in general psychiatry, for mood, as mood stabilizers. So it would depend on the medication that you're on. And it could be a combination. Often there are many factors involved. Also, depending on the type of seizures that a person has, if those seizures are allowed to continue, they can cause mood changes. So I would suspect, I mean, it depends on the medication and it depends on the type of seizures, but it might be a combination of both that would affect your mood. So like I said, the treatments are the same. So for example, the medications we use to treat depression, most of them are, they're a class of medication that are called SSRIs. They're the same medications that are used to treat anxiety. The benzodiazepines are also used for anxiety in the short term. We don't tend to put people on those for the long term, and that's because your body can get used to it. And especially in epilepsy. So, for example, a benzodiazepine is lorazepam, that's an or Ativan, people might know it as that. And especially in patients with epilepsy, some people will have a supply of lorazepam or Ativan in the event that they have a seizure. And so, particularly in patients with epilepsy, we don't want to use too much of that for anxiety because we don't want your body to get used to it. Because if you have a seizure and we give it to you, it may not work. So really, we tend to stick to the SSRIs, which are the same medications that are used to treat depression. The same medications and the same psychosocial treatment. So everything I said about treatment is the same for depression as it is for anxiety, because the topic was on coping and treatment. If the topic was more about what is depression, what is anxiety, then I would have spoken more about the two and how they're different. But I focused mainly on treatment and coping. In epilepsy, we talk about something that we call pre-ictal, ictal, post-ictal, and chronic interictal psychiatric symptoms. And essentially, the ictus is the seizure. That's what the word means. And so some people can have what we call somatosensory seizures, where you might have an emotional symptom as just before the seizure. So in other words, as part of the aura. And that could be a sudden feeling of dysphoria that kind of feels like depression. But that would go away after the seizure. That's pre-ictal. Ictal depression means that you actually have that as part of the seizure. You will never hear of it, it's hardly ever spoken of, and it's because there's no memory of it after the seizure. Post-ictal depression or dysphoria refers to that feeling of low mood that feels like depression, but it has kind of a different feel to it, much like the person who asked the question was describing. And like most post-ictal psychiatric symptoms, it can persist for several days, sometimes several weeks. And chronic interictal depressive symptoms are very difficult to distinguish from depression. So often we will just call it comorbid depression and epilepsy. And the reason is because at the end of the day, regardless of what we call it, the treatment sort of remains the same. And that is that we will need a biopsychosocial approach, and it may involve the use of antidepressants. It may involve changing epilepsy medications. Then I also had mentioned that there were many studies done, several studies looking at biological factors to determine is there certain biological factors that correlate with having depression and epilepsy, and none of them have panned out except a family history of depression. But the quality of the mood, if it's related to the seizure, particularly in post-ictal dysphoria, might be different than a person who is experiencing low mood, a person who has no epilepsy and is experiencing low mood or depression.
I should say that the particular extract that we're using is cannabidiol. That's the extract that stops seizures but doesn't make you high at this point. And we think it may have real help in terms of seizure control. I do not know whether it would have any help in terms of depression. To my knowledge, I don't have much knowledge. Sherese.
It was first, the indications for it were very, very specific. And they were spasticity and muscle pain from multiple sclerosis, anorexia associated with HIV, and anorexia, the medical term means a lack of an appetite. I don't mean the disorder anorexia. So patients with HIV who had so much anorexia that they were at medically unsafe weights, so their heart would be in trouble and they would die, and chemotherapy-induced nausea. And those were the limited conditions under which they were used. Since the idea of medicalizing it has come about, we, as a medical society, we have been prescribing it a lot more liberally, and that is because of anecdotes that it might be helpful for certain conditions, those being pain in general, chronic pain, anxiety, low mood, and epilepsy, seizure control. And we do not have guidelines for which to use it for those conditions, because so right now, one might say it's by patient preference. If the patient asks and if the doctor is okay with it, it gets prescribed. Now, before anything gets approved in medicine as a treatment, we have to have many, many, many studies. And there's different phases of those studies, and they go on for years and so on. Recently, in February, so a month ago, the first database, large database, which was approximately 19,605 patients from the US database, that was the first large evaluation of the use of marijuana for mood, anxiety, and pain. Unfortunately, it was not found to be any more effective than people who did not receive marijuana for mood, anxiety, and pain, and it is associated with a lot more cognitive side effects and volume reduction in cortical gray matter. And that is related to, if we are prescribing it, then we are using it frequently, meaning we're asking people to use a certain number of grams per day, which is also not decided because we have no guidelines on how to use it. So that's quite variable. There's no dosing guideline either. But people can use up to 3, like I've seen prescribed up to 3 grams a day. And you may have to take a certain number of puffs, a certain number of times per day, every day. And at that rate of use, it was associated with more cognitive dysfunction than any benefit for at least mood and anxiety. The study did not look at patients using it for epilepsy. This was for mood, anxiety, and pain. So the bottom line is that we are going to need a lot more research to guide certain things, like what are going to be the clinical indications for marijuana, what are the risks, what are the potential benefits, and what is the right dosing.
Really?
Okay. So yes, genetics play a part in all psychiatric disorders. The role that genes play differ depending on the psychiatric disorder. For example, the heritability for bipolar disorder is 47% in a monozygotic twin, meaning if you're a twin that came from, so you're identical twins, and one of your twin has bipolar disorder, there is a 47% chance that you might have that disorder as well. For schizophrenia, it's about the same, it's slightly higher, it's 48.7%. For depression, it's a little bit lower than that. It's more in the range of about 10 to 12%, but it depends on the degree of separation from the affected relative. So when we quote those high numbers, those are in identical twins, so you're sharing genetic material. Now, and it gets lower and lower, something like 5% for a sibling or something like that. Now, having said that, the genes for depression are different than the way we think about genetic disorders. When we think about genetic disorders, for example, sickle cell anemia or Huntington's disease, there is a gene, and you either have that gene or you don't. And if you do, if it's a dominant gene, you have the disorder. And if it's a non-dominant gene, well, you're going to have 2 copies of it to have the disorder. And that's a very fixed pattern. We can do mathematical calculations to tell you what are the chances, if you have 4 children, what are the chances that one will have this particular disorder. Depression and psychiatric disorders don't follow that genetic pattern, and that's because there's no one gene. There is no one gene for depression, and it's either you have it or you don't. That's number one. So many genes have been implicated, many different areas and many different genes have been implicated. Number two, while other genes, like the examples I gave for something like Huntington's or sickle cell, while if you have the gene, it means you get it, that's what we call penetrance. It means you have the gene, you're going to have this disorder. Genes for psychiatric conditions are called epigenes. And what that means is they're not likely to be expressed at all if the environment is protective. That is why in depression, in psychiatry, we talk about biopsychosocial, because there is nothing in psychiatry that's just biological. All the genes are epigenes. It depends on your environment. So despite the genetic loading, based on your environment, that's social, and your psychology, how you cope with things, how you respond to things, that's where psychosocial comes in. That is what depends, that is what determines whether that gene gets expressed or not. And that's why they are called epigenes and not just genes. So yes, psychiatric disorders have a genetic component, but they also have a very strong psychosocial component.
So at our last Eplink workshop, some of the feedback we got from our community advisory group, specifically the Epilepsy Toronto representative, indicated that memory problems are the biggest problem that their clients come to them with. So can we develop a research study that will help with memory problems? And so that's something that Eplink has started to work towards. And so in 2018, we hope to start a research study that will examine a semi-structured program that will have specific strategies targeted towards improving memory for people with epilepsy. So that's just something that's coming down the pipeline.
Maybe, Kat, I could ask you to expand a little bit on that. If people are interested in being part of one of these programs, how would they access it?
So you can visit our website at eplink.ca. You'll find a contact form where you can email us. You can also reach us through our various different social media channels. And I'm happy to give out my email afterwards if anyone would like to contact me. That's, again, I think that's an area that, again, requires a lot more research. We've had people come to us say, you know, my child with epilepsy has anxiety, or my child with epilepsy has depression. You know, what are some programs that are available for these children? And unfortunately, we don't have an answer. We've spoken to some of our researchers at Sick Kids, and again, there's no structured program or anything that's available. So again, that was identified recently as an area where more research needs to be done. And again, it's something that Eplink is planning to do with our renewal in 2018. So I'm sorry, I don't have any information about that.
One of our mottos is talk to someone who's been there. And even personally for me, I struggled with opening up about talking about my depression issues. And it took me forever to actually get there's so much stigma around it. There's shame. You don't want people to think badly about you. We have like peer support services at the MDO where you're basically given an opportunity to sit in a room with other people living with depression, where you could just sit there and people can talk. You can be anonymous within that group. It's a drop-in situation. And sometimes it's okay for you to just sit in the room and you hear about people doing the same things. The first time I went to a group, you know, people talked about those days when you can barely get out of bed or even brush your teeth. That was so empowering for me. People helped me get to one of those groups that was super helpful. If they're not ready for that, just try to sit back and listen, not give advice. That is always very helpful. We also have telephone support line where you can call in anonymously and just vent. You could offer some of those resources to your friend or family member. We also have specific family supports available. If that person is just not ready to seek out support, you need to support yourself too and your family, because that can often cause so much issues in the family itself. And if you're not in a good place to help support your loved one, that just makes it more difficult. So we've got a great Family Matters book online that you can get the information for upstairs. We can chat a little bit more about that. But yeah, that part is really important. It's sometimes really difficult for family members to help, but try to be as supportive and not judgmental or give specific advice. Sometimes people just need to just talk about it. You don't necessarily need to give someone an answer for what to do, but just give them the support to listen about all of the things that are kind of happening and why it's so challenging.
So much. Can I say something about that too? For me, I had to be ready. I had to be ready to hear another person and ready to help myself. And one of the things is my friend in the audience there, she invited me to church, and I thought, oh gosh, church. But I went along with her, and I talked to the pastor, and he listened without talking back. He just listened. And sometimes that's all we need, is someone to listen to us. And then after that, he take it from there. So I would say encourage the friend to go out and to join groups and join the church. Just go to somewhere that listen to you, not always you want someone to talk back.
It's important just to listen to see where a person is at and be able to sort of bring them to a point where they're able to take the one little step when they're in the worst place in their lives to be able to connect with a crisis center. And there's a number of different resources. We don't do crisis counseling at MDAO. We will chat with people if they're in a bad place, but if we feel that they're in crisis, we'll refer them to a specific crisis center. But there's a number of resources upstairs, and we'll send the links to that after the event as well.